Hi, my name is Joel Abraham, and I'm a New York State Certified Instructor Coordinator and a member of the New York City REMSCO Training and Education Committee. The seizures protocol for adult and pediatric patients were combined into one protocol. Medications are now weight-based for both adults and pediatrics. Midazolam is 0.2 milligram per kilogram, which can be administered IV, IM, or IN. Lorazepam is 0.1 milligram, which can be administered IV, IM, or IN. And diazepam is 0.2 milligram per kilogram, which can only be administered IV. The preferred route for benzodiazepine administration is IV. If there is no IV access, use the quickest route available, preferably intranasal over intramuscular. Due to the quicker onset of action of midazolam, it is the preferred medication to treat seizures, followed by lorazepam and diazepam. If you need to give additional doses for patients that continue to seize, you should use the same benzodiazepine rather than switching to a different medication so as to not risk potentiation. For pregnant patients in their third trimester or who have delivered within the last 1 month, you should consider eclampsia as a cause of seizures. As a reminder, there is a section on eclampsia included in this protocol update. When you are uncertain of your patient's weight, use ideal body weight when dosing any of the above medications. For male patients, that would be 50 kilograms plus 2.3 kilograms for every inch above 5 feet. For female patients, it would be 45.5 kilograms plus 2.3 kilograms for every inch over 5 feet. Now we're going to cover the abdominal pain, severe nausea, severe vomiting protocol for both the adult and pediatric patients. The age limit was changed to now be from 6 months and older, and the dosage was changed from 2 doses of 4 milligrams to 1 dose of 0.1 milligram per kilogram given via the oral route, IV or IM, to a maximum of 8 milligrams.
Hi, I'm David Skolnick, paramedic and member of the New York City REMSCO Training and Education Committee. We're going to review 2 protocols in the January 2022 protocol update. The first protocol, severe sepsis and septic shock for both the adult and pediatric patient. In order to meet criteria for this protocol, your patient has to have a presumed infection and any 2 of the following clinical abnormalities. In the protocol, there is a chart, as you see here, listed, divided by the adult and pediatric, which has abnormal vital signs, abnormal temperature, and then signs, symptoms, and abnormal lab values. And you need any 2 of these abnormalities plus a presumed infection in order to meet criteria. So a heart rate of greater than 110 for an adult, a respiratory rate of greater than 20, or an end tidal less than 30, systolic blood pressure of less than 90, or a MAP of less than 65. Now, we're also going to have MAP as an option when we're titrating our vasopressors, okay? Now, MAP is given to us on our monitors. Depending on which monitor you use, here the arrows are pointing to where you could find MAP on your machine. Okay, you have to have abnormal temperature, altered mental status, abnormal lab values if you have that available to you. Okay, the pediatric patient, high heart rate, high respiratory rate, abnormal temperature, altered mental status, poor perfusion. Any 2 of these abnormalities with a presumed infection, you meet criteria. Okay, for the paramedic, for adult patients, obtain intravascular access via large bore IV or IO. Consider IO access for pediatric patients if needed. Okay, you then start with 20 ml per kilogram IV of crystalloid fluids. As in other protocols in this update, fluids are now weight-based, and here, as in other protocols, 20 ml per kilogram IV of fluids to start. For adult patients who remain in shock after the initial 20 ml per kilogram IV, administer one of the following to maintain a systolic of 90 or a MAP of 65. Okay? Option A is to give another 20 ml per kilo of fluids, which would bring you up to a max of 40 ml per kilo. Option B, start a norepinephrine drip, 2 mics per minute to a max of 20 mics per minute, titrating every 3 to 5 minutes again to that systolic of 90 or MAP of 65. And option C would be epi 10 mics IV over 1 minute, which is push dose epinephrine, and repeat as needed every 3 to 5 minutes. Okay. Medical control options would be to administer any of the standing orders. But for adult patients, you have the new option of a vasopressin drip, where you would titrate it every 3 to 5 minutes to systolic of 90 or MAP of 65. Vasopressin is for, hypotension refractory to the other vasopressors, or if you don't have other pressors due to limited availability. For pediatric patients, after the initial 20 ml per kilo, you don't have anything standing orders, you have to get on the phone. You have 3 options for a pediatric, okay? Either you give another 20 ml per kilogram, just like an adult, so 20, and then you call for the second 20. Option B would be push dose epi for pediatrics, which is new. That's 5 micrograms IV over a minute, repeat every 3 to 5 minutes. Option C, also new, is norepinephrine for pediatrics, 0.05 mics per kilo per minute, and you would titrate that as needed every 3 to 5 minutes as well. Okay? Just to review, adult patient, you start out 20 ml per kilogram. If they're still in shock, on standing orders, you have 3 options: fluids, norepi, push dose epi. If that's not enough, you can get on the phone, you could do any repeats of the standing orders, or call for vasopressin. For a pediatric patient, after the initial 20 ml per kilogram, and they're still in shock, you have nothing on standing orders, you would get on the phone to call for either fluids, push dose epi, or norepi. Under key points and considerations, it discusses peri-intubation hypotension could lead to patient decompensation and cardiac arrest. You should attempt to bump their blood pressure through a fluid bolus or vasopressor before you intubate them. And any vasopressor infusion must be administered using a dial flow or IV flow regulating device or an IV infusion pump. Okay. Appendix O in the appendices is now vasopressor infusion rate. So you have these dosing charts in the appendices to help you with these vasopressors. Okay. In the GOP, vasopressor medication administration, all continuous vasopressor infusions must be administered through a regulating device or pump. And the vasopressor infusion should preferably be given through an 18 gauge or larger IV catheter. Okay, the second protocol is undifferentiated shock. So now most of the vasopressors are either in sepsis or here in undifferentiated shock. There are some pressors listed under bradycardia for heart rate, but most vasopressors are here in undifferentiated shock. Okay. The protocol is for patients who are persistently hypotensive and symptomatic from an unclear etiology, or who are persistently hypotensive despite treatment under other existing protocols. Patients with shock due to specific reasons, like trauma, cardiac dysrhythmia, sepsis, anaphylaxis, should be treated accordingly. Okay? So this is like an all-encompassing protocol to treat patients in shock. You would start out, just like we just did in sepsis, 20 ml per kilo IV, standing orders. For patients who remain in shock after the initial 20 ml per kilo IV, you would administer one of the following pressors with the goal of maintaining a systolic of 90 or a MAP of 65. Option A, 20 ml per kilo again, which would be a cumulative dose of 40 ml per kilo. Norepi, 2 to 20 mics per minute. Push dose epi is option C. And here you have option D, dopamine, 5 to 20 mics per kilo per minute, which you did not have in sepsis. So you have dopamine here, standing orders, after the initial 20 ml per kilo. Okay, you can get on the phone to repeat any of the standing orders, or we can give vasopressin here as well with a medical control approval. Okay, a review again after the initial 20 ml per kilo and the patient is still in shock. Standing orders, we can give additional fluids, norepinephrine, push dose epinephrine, dopamine, or you can get on the phone, you have the repeats, and vasopressin. Again, key points of considerations: peri-intubation hypotension can lead to patients going into cardiac arrest. You should give fluids or vasopressor before you intubate them, and any vasopressor must be given through a flow regulating device or an IV infusion pump. Thank you.
Hi, my name is Robbie Zeitz, and I'm a New York City paramedic and a member of the Training and Education Committee. I'm going to be covering several topics today, the first of which is the stroke protocol. This covers both adult and pediatric stroke patients. There are a couple of things that we want to remind you of. Number one, the total time from onset of patient symptom to EMS patient contact is less than 24 hours. We use the SLAMS scale to evaluate our patient. We use it during our initial contact with our patient, and we should continue to evaluate our patient with the SLAM scales during our transport of our patient. If they suddenly meet criteria, we must stop and contact online medical control to decide what the most appropriate destination is for our patient who has now become inclusive in the SLAMS criteria. We must also ascertain the patient's last known well time in order to ensure that they meet the time frame involved in a patient going into the stroke category. And then finally, we must radio notification for primary stroke center in order to make sure they know we're coming and that they're ready to receive the patient and there's no delay in getting the patient to definitive care. Let's spend a few minutes talking about the protocol. First and foremost, we must obtain a blood glucose level. This is for EMTs and paramedics as well. Remember that in regards to hypoglycemia, that condition can mimic an acute stroke or symptoms of a TIA. In addition, hyperglycemia is also an important diagnostic differential that has been reported to cause focal-neurological deficits masquerading as strokes. So it is extremely important that we do a blood glucose level. As a matter of fact, in the 2021 Quality Improvement Project that is now ongoing within the region, we are attempting to increase the percentage of stroke calls in which a blood glucose level is obtained. Our goal is to improve it from the current 79% average to over 85% in the next 6 months. Remember, the BGL obtainment for an AMS patient is the standard of care within our protocol. So we're going to check to make sure that the BGL for our patient is greater than 60. If it is, then we are going to move on to using the SLAM scale. Remember to determine each component and the total score of the New York City SLAM scale by interviewing the patient, the family, and or bystanders. As we mentioned before, determining the last known well is very important because we need to try and determine the exact time of symptoms onset. As a reminder, this is the SLAM score that we go according to. We have a facial droop. If it's absent at 0, it's present as 1. Our arm drift, absent 0, drifts down 1, falls down rapidly is 2. A speech deficit, absent is 0, present is 1. And grip strength, normal is 0, weak grip is 1, and no grip is 2. So our score on the SLAM scale is anywhere from 0 to 6. For patients that fall into the category of hypoglycemia, which is where their blood glucose level is less than 60 milligrams per deciliter, then we are going to treat according to our hypoglycemic protocol. Remember that for neurological symptoms that resolve after appropriate hypoglycemic treatments, The patient then gets transported to the closest appropriate 911 receiving hospital. However, for patients whose neurological symptoms persist after appropriate hypoglycemic treatment and their blood glucose levels have proven to be greater than or equal to 60 milligrams per deciliter, then we need to continue and evaluate them for a possible stroke using the New York City SLAM scales. Remember that our patient needs to be transported to the closest appropriate stroke center, which is Appendix I for the hospital specialty capabilities, as needed and as appropriate based on the SLAM scales. New to the protocol this year is a medical control option for paramedics, which is the administration of metoprolol 5 milligrams IV slow push for a blood pressure in a patient of greater than or equal to 210 over 120 millimeters per mercury. This is if it is available for your particular agency. This is done through an 18 gauge IV. Again, is a slow IV push. Just as a review, some key points and considerations. Transporting patients should be done to the closest appropriate stroke center as determined in the GOP and the appendix for your stroke patient. For pediatric patients with symptoms of acute stroke, you need to contact OLMC for a transportation decision to a hospital with pediatric critical care capabilities. Remember that if a patient has an SLAM score of less than 3, transport the patient to the closest appropriate stroke center. However, if our patient has an SLAM scale of greater than 4, you should contact the OLMC for a transportation decision to the most appropriate thrombectomy stroke center, unless the patient meets one of the following exclusion criteria. 1. Total time from onset of patient symptoms to EMS contact is greater than 24 hours. 2. If a patient is wheelchair or bedbound. If a patient is a seizure patient and that seizure is the cause of the neurological symptoms. Loss of consciousness. If trauma is the cause of the patient's neurological symptoms, or if the transport time to a thrombectomy center is greater than 30 minutes. These are all key points and considerations that we need to remember in terms of the stroke protocol.
Now we're going to cover the abdominal pain, severe nausea, severe vomiting protocol for both the adult and pediatric patients. The age limit was changed to now be from 6 months and older, and the dosage was changed from 2 doses of 4 milligrams to 1 dose of 0.1 milligram per kilogram given via the oral route, IV or IM, to a maximum of 8 milligrams.
Now we're going to cover the hyperglycemia protocol for both adults and pediatrics. Please keep in mind that this is a single protocol for both adults and pediatrics. As an EMT, you should obtain a blood glucose level and request ALS assistance for patients with a blood glucose level of greater than 300 milligrams per deciliter and any of the following conditions: altered mental status, tachypnea, or signs of dehydration. If ALS is unavailable, or if the time to intercept ALS is greater than the time to arrive at the hospital, then you should transport your patient immediately, notifying the hospital of your incoming patient's condition. As a paramedic treating this patient, you should evaluate the patient's airway and determine whether you need to perform advanced airway management or not for this patient. That should be an ongoing part of your assessment while treating this patient. For a patient with a BGL of greater than 300 milligrams per deciliter and any of the following conditions: altered mental status, tachypnea, or signs of dehydration, or a patient whose BGL is greater than 500 milligrams per deciliter, you must obtain, or you should obtain, intravascular access for the patient. Remember that the glucometer may be reading high, HI, or check ketones. You should be familiar with the glucometer that your agency uses to determine what the BGL level would be if the glucometer reading is high or check ketones. If intravascular access is obtained, then you should administer 20 milliliters per kilogram of IV crystalloid fluid, up to a maximum of 1 liter, and then you should begin cardiac monitoring. Remember, this is both for adults and pediatrics. In addition, there is a medical control option of administering an additional 20 ml per kilogram of crystalloid fluid, again with the max of 1 liter. Remember that you should document the total amount of crystalloid fluids administered to your patient on your EPCR. The next protocol we're going to cover is decompression sickness for both the adult and pediatric patient. As EMTs and paramedics, we are to transport patients with any signs of and symptoms of decompression sickness after diving and along with their companion divers to the closest hyperbaric center. There is no need to contact online medical control for authorization, as this is the only treatment locations that would be able to appropriately care for these patients. The hyperbaric centers in New York City are located in 3 hospitals, either Hospital 14, New York Presbyterian Cornell. Hospital 25 is Jacobi Hospital in the Bronx, as well as Hospital 82, Nassau University Medical Center in Nassau County. These are the only 3 hyperbaric centers in New York City. Signs and symptoms of decompression sickness include neurological signs such as abnormal gait, dizziness, extremity weakness, and numbness. Cardiac and respiratory symptoms can include chest pain, difficulty breathing, and hypoxia. Patients can also present with gastrointestinal problems such as abdominal pain, nausea, and vomiting. Musculoskeletal issues such as joint and or muscle pain, painful range of motion, as well as skin, rash, and or itching. Some of the key points or considerations when treating patients with decompression sickness is that you must transport patients as determined by the general operating procedures to the closest appropriate hyperbaric center. Bring all the patient's dive computers, dive watches if available, with the patient to the hospital. If possible, obtain the following information. Specific information for the dive includes maximum depth, total time spent underwater, bottom time, time of ascension to surface. In addition, the mixture of compressed gases used during the dive or dives, any improvement of symptoms since ascension to the surface, and the time since the last dive was completed, and any air travel history since the last dive. Remember that decompression sickness may not happen immediately after the dive, and there may be a delay, and you may not get the patient until several hours or days later after they've traveled from where they did their diving.
There is a new protocol named General Pain Management, which allows paramedics to administer an analgesic medication for pain management. Previously, the protocol had a standing order to administer morphine or fentanyl to a patient who had an isolated extremity injury or a non-airway burn. Giving these medications to patients with other conditions required a call to telemetry first. This new protocol allows for pain to be treated in additional medical conditions as standing order, as well as adds additional medication options. The incident of this protocol is mainly for patients who have acute pain, such as from a suspected fracture, burns, or a patient having sickle cell pain crisis. Generally, EMS does not give pain control for chronic pain, unless it is a severe acute exacerbation of chronic pain. Some patients with possibly complicating medical conditions will still require an order from the online medical control physician prior to the administration of any analgesic medication. These specific conditions are listed in the beginning of the protocol and include altered mental status, hypoventilation, hemodynamically unstable, pregnant or suspected of being pregnant. There is also a note in the protocol stating that these patients should be monitored using non-invasive capnography, if it is available. Now let's talk about the medication options. Morphine, 0.1 milligrams per kilogram, IV/IM, maximum 10 milligrams, if systolic blood pressure is greater than 110 millimeters of mercury. Fentanyl, 1 microgram per kilogram, IV/IM, IN, maximum 100 micrograms, with a repeat dose if needed. Ketorolac, 10 milligrams, IV/IM, adults only. Acetaminophen, 15 milligrams per kilogram, PO, maximum 650 milligrams, pediatric only. Morphine and fentanyl have been used for pain control by medics in our system for many years, and you should all be very familiar with these. Fentanyl is rapid onset, but it wears off quickly. It may be a good choice for something like a shoulder dislocation that may be rapidly relocated in the ER. A longer-acting opiate, like morphine, is a better choice for pain that will last longer, like from a tib-fib fracture or sickle cell crisis. Note that fentanyl does not decrease blood pressure as much as morphine, so fentanyl would be a better choice for a trauma patient with a femur fracture. For the adult patient, ketorolac is now an option. Ketorolac, also known by the brand name Toradol, is an NSAID like ibuprofen. It should not be used for possible fractures or abdominal pain or any other condition where bleeding is possible. This is because ketorolac can cause platelet dysfunction and worsening bleeding, which is a concern for injuries or patients who may need surgery. It is a good medication for treating pain from a kidney stone. Take note that the protocol allows for the additional administration of an opioid, such as morphine or fentanyl, as standing order, if ketorolac does not control the pain. Since ketorolac does not have its peak effect until about 30 minutes after administration, the opioid should generally not be given before that time. For the pediatric patient, oral acetaminophen, also known as Tylenol, is now a standing order option. Please be sure to pay special attention to the weight-based dosing in this case, which is 15 milligrams per kilogram with a maximum of 650 milligrams. Finally, there are medical control options for additional morphine or fentanyl or ketamine. We are excited for this new protocol and believe it will now allow for better care for patients in acute pain.
General pain management is a comprehensive protocol to help organize all pain management options in one streamlined location. Begin with getting a 3-lead EKG, SpO2, obtain IV access, and vitals every 5 minutes. Then, based upon availability, we will give one of these meds. They are listed in a specific order as the preferred treatment options. As the video mentioned, morphine, although it has a longer lasting effect, it can drop the BP, so the systolic blood pressure has to be above 110 millimeters of mercury, max of 10 milligrams per dose. It now also has a maximum of 10 milligrams in a single dose. This should be your first option. Fentanyl is short-acting and short-lasting, and it can be used if the blood pressure is good to a little on the lower side. At 1 microgram per kilo, it is a good second option for IV, IM, IN. It has a max of 100 mics with a repeat after 10 minutes, meaning total of 200 micrograms. Toradol has been added for the adult patient as option C, and Tylenol has been added for the pediatric patient. Ketamine has been added as a medical control option, and just like the rest, it too is weight-based. Online medical control should be contacted prior to the administration of analgesic medications for any of the following conditions. If the patient is ALS, the patient has hypoventilation, is hemodynamically unstable, pregnant or suspected of being pregnant. Patients should also be monitored using non-invasive capnography if available for all pain management. An easy way to remember the ketamine medical control option, IV has 2 letters, therefore it is 0.2 milligrams per kilogram. IMIN has 4 letters, 0.4 milligrams per kilogram. Please remember to push ketamine slowly to avoid apnea as a potential side effect. Pregnancy, abdominal pain, renal failure or patients on dialysis, and an age greater than 65, as well as bleeding or internal injuries and or fractures are all contraindications for Toradol. All pain meds are based upon ideal weight, and as always, when administering opioids, monitor the patient for hypoventilation. Procedural sedation is a new protocol used for conscious patients that require some medication for either short-term, including pacing, synchronized cardioversion, or for CPAP usage, or for long-term, such as advanced airway management. In order for procedural intubation to occur, all the following must be met. The patient must be an adult over 18 years old, confirmed AMS, have respirations less than 10 per minute, SpO2 less than 90% without oxygen, and no other underlying causes that could be reversed, such as an overdose or hypoglycemia. For basic sedation, short-term usage for pacing and cardioversion, an adult patient will be given based upon these options: etomidate 0.15 mg per kg, IV max of 20, or Valium 0.1 mg per kg, IV max of 10, or Versed 0.1 mg per kg, IV max of 5, or Ativan 0.02 mg per kilogram, IV route max of 4, and finally ketamine 1 mg per kg, IV with a maximum of 100 milligrams. The protocols affected include respiratory distress and dysrhythmias for the adult patient. Please note, excited delirium does not fall under procedural sedation. It has its own guidelines and its own dosages. To recap, for all procedural sedation, begin with ABCs and vital signs. Administer O2, obtain IV access, and begin cardiac monitoring, and monitor the vital signs every 2 to 3 minutes. For sedation to perform advanced airway management, all of the following criteria must be met. The patient must be an adult, AMS, resps less than 10, SpO2 less than 90% with no immediate reversible causes, and O2 via high nasal cannula has been removed. For advanced airway, the dosages are slightly different, although still weight-based. Etomidate is going to be 0.3 mg per kg with a max of 40. Valium is 0.2 mg per kg with a max of 10. Versed 0.2 mg per kg with a max of 5. Ativan 0.1 mg per kg with a max of 4. And ketamine can be 2 mg per kg IV with a maximum of 200 milligrams. Let's try a little comparison with a side-by-side view. We can see the differences. Etomidate is doubled with a double maximum for airway management. Valium is doubled for the initial dose with the same maximum dosage. Versed is doubled with the same max, and Ativan is very different with the same max of 4 milligrams total dose. Ketamine is also doubled with a double max for airway management, just like etomidate. Post-intubation of the adult patient, your choices for continuous sedation include Valium 0.2 mg per kg with a max of 10, IV, Versed 0.2 mg per kg with a max of 5 milligrams, IV, Ativan 0.1 mg per kg with a maximum of 4 milligrams, IV, or ketamine 1 mg per kg with a maximum of 100 milligrams, IV. Key points to remember: etomidate is short-acting, so it's great for cardioversion, but it cannot be used post-intubation for continuous sedation. If procedural sedation was successfully used to intubate a patient, using the same benzo is better than switching between medications. And although the ideal body weight is estimated, please try to estimate accurately. If the BVM isn't working and you need to secure the airway, and you feel that intubation will be difficult, go with less invasive devices, such as a combi tube, a King, or an LMA, even an iGel as available, etc. And finally, you and your partner should constantly be monitoring the patient. The BP may drop as you're getting ready to intubate, so be prepared with IV fluids or vasopressors as necessary.
Pause. Vaccinations given at a pod is pause. I don't know if we're going to do this one, or maybe Morty will do this one, but I'm going to record it just in case he doesn't have time to. There's a new protocol for vaccine administration. Please note, vaccinations given at a pod is under the medical director of that pod, and instructions are to be followed regarding that site's operation. Refer to Appendix Q for contraindications and precautions, and refer to Appendix O for vaccinations for the appropriate vaccine preparation instructions.